you please welcome our first speaker, Chris.
Well, good morning, everyone, and I will say that this is going to be some challenge because I was asked to present a lot of information in a short period of time, but I wanted to thank NACCHO for giving us an opportunity to tell our story in Cuyahoga County. So how are we advancing the slides?
There's a clicker there on the right.
Oh, very good. Excellent. Okay, so what I hope to cover, besides learning how to advance the slides, is the story known as the Health Improvement Partnership Cuyahoga, or we like to call it HIP-C. Talk a little bit about it from planning to implementation, where we are, where we hope to go, how did indicators shape our HIP-C process, and how to build the foundation of equity. HIP-C is a county-wide effort, and that is significant because of the fact that we have 3 health jurisdictions within Cuyahoga County. Furthermore, we have a large city-based initiative. For those of you that are not familiar, Cuyahoga County includes the city of Cleveland, and so they have their Healthy Cleveland initiative. There's another county-wide initiative that the local county government has with municipalities. And then there's also a regional effort that is going on with more than probably 5 to 7 counties beyond Cuyahoga County. So the fact that we can get everyone to agree that this is one of the important initiatives and amongst the competing priorities that are out there is fairly significant. A little bit about the vision and the mission. I think the things that I want to highlight here as you take a look at the information there is that this is a community-driven process. It is not one of those initiatives where we could say, you know, hi, we're from the government, we're here to help, we know what's good for you. Right? This is a community-driven initiative, and we are committed to using data from the assessments. We are also recognizing that this has to be a collaborative approach, because what we're trying to do and what you'll hear about in a few minutes, no one agency or entity can really take on this transformation that we're trying to achieve within Cuyahoga County. Partnerships. We have over 50 different organizations engaged in the HIP-C planning process, and that represents over 100 individuals. We have community members that have come to the table to help inform us. We have a steering committee of approximately 17 individuals that help guide and coordinate the consortium work. We work with Common Health Action, and we'll talk a little bit about why that is an important partnership to this endeavor. And then we have had funding sources to help assist some of our infrastructure needs, as well as bring experts and resources to the area to assist us develop capacity. How many of you have heard of the MAP process, mobilizing action through planning and partnership? There's a couple of you out there. So this is a process that you see there in the one graphic that involves many different cycles, many different assessments. And given the nature of the conference here today, I'm going to focus in a little bit on the community health status assessment. To give you an idea of where we're at in this cycle, we are just getting ready to go from plan to implementation through our project, and I'll talk a little bit about that later on. So here's a brief summary of the different assessments that were part of the MAP process. You know, your traditional community health status assessment and the list of indicators, and that's what I'll drill in a little bit deeper in a moment. The community themes and strengths assessment, we developed a survey and took it out to the community and asked them to tell us what they felt were important in their eyes. We also reached out to youth to get their voices heard through a photo voice project, and then we held some stakeholder interviews. The Forces of Change assessment was really this brainstorming session that helped identify those factors and those things that are going to be able to help us or potentially challenge us given the climate. And then the local public health system assessment, that's really the first assessment that we started with, and it goes beyond just the local health department. For those of you that are aware of the notion of what the local public health system is, it really includes academia, it includes the community, it includes business, it includes basically everyone that has involvement that touch people's lives. And I think the thing that I want to impress upon you is that we recognize what we're trying to do is just not simply a list of indicators that we're trying to impact. It's much more than that. So I'm going to zoom in a little bit about on the community health status assessment. We formed a subcommittee that included representation from 12 different agencies, mostly data-minded individuals. We reviewed potential indicator lists from 4 primary data sources that totaled approximately 300 indicators across 11 categories. 2 of those were the NACCHO Community Health Status Assessment, both the core and expanded indicator list, the Robert Wood Johnson County Rankings Project, and then our state health department had undergone their state health status assessment, and so we took a look at the indicators that they had considered in their project as well. We developed an online survey, and then we asked our membership to vote on the top 5 indicators from each of those 11 categories. So, and through that process, that is how we developed what indicators we would be using for our health status assessment. And here you can see that there's a wide range of categories that we used in thinking about the indicators. Next, I'd like to talk a little bit about the general structure of the indicator profiles. When we started this, we tried to identify the most current data available. At that time, it was 2010 data. If possible, we wanted to stratify the data into different groupings. We wanted to take a look at the information through age, gender, race, ethnicity, and then 2 levels of geography, the county overall, and then the city of Cleveland. As I indicated, the city of Cleveland is part of Cuyahoga County, and in order to help get buy-in from them, we had to make sure that they knew that we understood the importance of elevating that community and be able to present information that they would find useful for their Healthy Cleveland initiative. And then the other thing that we were very intentional in doing was to benchmark our local information. So we had to try to make sure that, okay, if we were able to find data on these indicators and begin to tell our local story, what is our local story relative to what benchmarks are out there, be it state or national data. Regarding benchmarking, one of the things that we were intentional at looking at was how well did our indicators tie to the Healthy People initiative. And you can see here that I think we did a pretty good job with that tie. 47 out of the 55 indicators that we selected had either direct or indirect linkages to the Healthy People initiative. And so we felt pretty good about being able to do some of that benchmarking of our community against this standard. So now I'm going to share with you just quick examples of the layout, and I know that's rather small up there. So basically we created an at-a-glance summary for the indicators that told you what the indicator was, the time period that it covered, what the rate for the overall county was, what the rate for the city of Cleveland was, what the national benchmark was if it was available. And so this was a nice at-a-glance approach to be able to take a look at the information. We then looked at things and charted things out by race and ethnicity, those 5 groups that I talked about earlier, age, gender, race, ethnicity, and then we benchmarked it against the national benchmark. Similarly, we did it for gender, and then we did it for the age groups that I indicated earlier. So this just gives you a feel for how we laid out all the information across each of the indicators that we selected. Alrighty, so I talked about how we used the MAP process and we went through these 4 assessments. We also went through a period to try to identify strategic issues, and I'll talk a little bit more about that. We went through several rounds of discussion to try to prioritize and rank what strategic issues we were going to work on. And then the other thing that we did was we took a look to see how well we were aligning with the national prevention strategy as well as the state health improvement plan that was put out. And so at the end of the day, we are really 2 strategic issues that emerged from our information. And the 2 are listed here. How do we create safe, supportive environments across all levels of community to foster healthy living? And then how can we create access to quality and equitable care for all within the community in a variety of settings? So these are the 2, I would say, 10,000-foot view issues that emerged. So then what we did is we had the partnership generate a potential list of issues, strategic issues that we would consider. And I don't know if you can read that or not, but the list included traditional public health issues considered more downstream, as well as complex social issues. And really this was a turning point in our process, because we knew that even though this group identified 15 different strategic issues, we really were only going to select 1 to 4 to start with. And we also recognized that many people in the room did not really understand or even know how to apply an equity lens to the selection of these priorities. And we didn't want to really end up with those traditional downstream priorities. We wanted to have a mix of things to look at. So at the end of the day, the 4 priorities that emerged were to improve chronic disease management through the engagement of various sectors, to improve coordination between clinical care and public health to improve population health, to eliminate racism as a social determinant of health, and to increase access and opportunity for improved nutrition and physical activity. So those are 4 strategic issues that we've decided to focus in on. Here is just an example of a tool that we use to help generate those strategic issues. And so what we asked folks to do is to consider those 4 data assessments. And then from those 4 data assessments, pick out the portions of the data that support this strategic issue that you're indicating you want to be considered during that voting process. And so this is just a helpful tool to assure that data is used in that process as opposed to just someone's passion for a particular issue. So now we're at the point where we identified what strategic issues our community said was important. We went through and said, okay, we're going to focus in on these 4. But then we actually had to go through and then develop goals and objectives and identify strategies that would help move the needle within each of these 4 strategic issues. And so we were very deliberate on how to go about that. We took the strategic issues out to community conversations to get input from community members. You know, did they understand what the strategic issue was saying? We did an environmental scan. We asked people to tell us what they were aware of relative to what was going on across the community for each of these strategic issues that were selected. And then, most importantly, we asked people who were going to commit to helping us work on these goals and objectives to commit to a day-long health equity workshop the day before we began our session on objective development. And that is when we recognized that that was going to serve as a foundational piece to assuring that we begin to create this equity lens for individuals and also pay attention to the social determinants of health. So just to remind folks about equity, what this, we often like to use this, and this is something that Common Health Action brought to the table here. The light doesn't show up very well. But the point of this is that equity is really recognizing that folks are different, right? And in this illustration, we have a situation where we have different height children. And some may think that, you know, it's equitable or fair, that if we just gave everyone the same something, that would be good enough, right? So every one of those children there have a crate to stand on. But yet, if you look closely, not all of them could view the game that was intended to be viewed. And so it's recognizing, and the equity lens portion of this is to recognize that there are different needs within the community, within people. And that if we reassemble things, recognizing we can then hopefully optimize the opportunity for individuals to achieve health. Some of you may be familiar with this published document in 2011, American Journal of Public Health, and it actually illustrates the actual causes of death. How many of you have seen this before? So only a handful of you. So the point of this slide is to recognize that there really are these other factors, these non-traditional factors, these upstream approaches that are the actual causes of someone's death. And to that end, this is another graphic we like to use to really show those social determinants of health. How many people have seen this graphic before? Not as many hands go up. And so the point of this graphic is to illustrate that there is a lot more than just personal behavior. There are a lot more than just personal determinants, you know, that genetic package that we really don't have much of a say-so in. And that there's a ring of systems at multiple levels that all interact how one ends up healthy or unhealthy. And this is another way to look at it. You know, when inequities are high and the community assets are low, health outcomes are worse. And that's illustrated by the tree that isn't being really nurtured or growing to its potential. Whereas if you minimize inequities and have community assets that are high, health outcomes are best. So the framework that we really have been trying to promote and get folks to understand relative to this upstream and downstream approach is one that came out of the Bay Area. It was something that was introduced to us by Dr. Tony Eitan. He came to us in 2008, 2009 and began to help us understand this much better. And as you can see, the upstream issues are more of the socio and system issues that impact health. And then on the right-hand side are the medical model, the traditional risk factors, behaviors, and the things that we look at. And when we look at the things that are more downstream, that's when we start to see the health disparities. But when we look upstream, that's really where a lot of the health inequities are occurring. In terms of resources for equity training, these are many of the cornerstone organizations and initiatives that helped us begin to develop capacity to address equity. So as we began to move through the early phases of our health improvement planning process, we recognized that our internal staff and leadership and partners were just at a wide spectrum of understanding the importance around equity. And, of course we shared the maps and the health disparity indicators, but that just really appealed to the minds of individuals. And if you're familiar with any type of equity work, you really need to understand that you need to get at people's hearts. They need to understand that there truly are differences, and it's more than just data. That you need to go through this perspective transformation to really begin to make this meaningful work. And so that's what we began to achieve through these health equity workshops and our engagement through some of those resources that I described earlier. And one of the biggest resources that we've leaned on continually is Common Health Action. They created that equity grounding for us, helped begin to really allow our group to understand the issues associated with equity and racism, as well as other isms that are drivers that cause many of the inequities that we're dealing with, in turn affecting the health outcomes. We recognized that we really needed to change our vision that reflected a new narrative in public health, because if you think about it, public health isn't necessarily responsible or traditionally working in the space of those upstream factors. And so we needed to really move beyond healthcare and personal responsibility, and we really needed to begin addressing those root causes of health disparities and inequities through authentic community engagement in policy, system, and environmental change. And that's really where we see making the biggest impact, but we also recognize that that is going to be a long journey and a challenge for us to be able to make policy and systems level change. Some of the core values that we think are important in our work: collective impact, right? Beginning to coordinate partnerships and align priorities and action and mobilize resources to make that happen. Community engagement at all levels of the process: planning, decision making, and actions. And then health and equity in all policy, really trying to get this notion of this culture of the equity lens into the decision-making process across all sectors, systems, and policy areas. Switching gears a little bit then, we have a work group that I help coordinate. It serves as a technical advisory for the priority areas for HIP-C. They provide oversight to help begin thinking about how we're going to measure some of these things. You know, what metrics can we put in place to do that? What system are we going to use to help demonstrate progress? How many people are familiar with the next generation evaluation? Just a couple. This is something that we had to recognize and are still learning and educating ourselves on, because it moves away from traditional evaluation. It really starts to focus in on systems level evaluation, recognizing the need to provide more feedback in a timely manner, and really engage many people with that data collection process. And with that, because we're embracing these tenets of next generation evaluation, there are challenges, to be sure. Most of our training and expertise is geared towards traditional evaluation approaches. Partnerships willing to share success and their failures. I mean, this is essentially a learning collaborative. And then what type of sophistication is the system going to be for sharing this information? Communication and media, very, very important. Interestingly enough, we had a session on that prior to this. And as we sit here today, there are folks that are being trained by the Berkeley Media Studies Group to help us craft our messages, because this is a very complicated story to tell. And so I'm just going to leave you with a couple final thoughts based on some local data. First, where we're at, our work groups for each of those four selected priorities developed their objectives, developed work plans. We were finalizing our health improvement plan document, our CHIP, and something interesting happened. The CDC's FOA came out for the racial and ethnic approaches to community health. So we called a timeout, and we actually wrote an application for that, and we just found out last week that our work was funded. So that was very exciting, very exciting. So then now we have to go back and finalize that CHIP and then reach out to the community and talk about it. Now, I'm going to share a real quick story with you, I promise. Here's our county, and here is poverty and the distribution of poverty up on the right, or the left, excuse me, and then the percentage of African American population in our county. See similarities in the distribution there? High concentrations of poverty in African American population in those areas. Here's a Hispanic distribution for our county. You can see the similarities. Now, how many people know about redlining? So redlining is a practice that was used to help determine what areas in a community would receive federal backing for loans. It was deemed illegal, and it was a very discriminatory practice, but it had long and still has long-reaching effects on communities. Take, for example, these same two maps that I showed you earlier. There's the redlining mapping for our community. Striking resemblance to what we're dealing with today, right? In terms of poverty and the distribution. Here's our infant mortality rate from 2008 through 2010 at the top. There is our life expectancy map for our county. There is redlining. Amazing correlations. Not by accident. Not by accident. So I just want to give a special thanks to Martha Halco. She is our HIP-C leader and champion. She is inspirational, tireless, and truly dedicated to transforming the community I call home. She told me that she can't do it alone, and she's grateful for all of our work. I say it's time to move upstream. Thank you very much.
Thank you, Chris. That was great. Now, just briefly, I'll introduce our next speaker.